Welcome to this video, where we'll be discussing a critical topic in intensive care: dyspnea in acutely ill, mechanically ventilated adult patients. Dyspnea, or difficulty in breathing, is one of the most distressing experiences for patients in the ICU, particularly those on mechanical ventilation. Understanding and managing this condition is vital for improving patient outcomes and reducing suffering. In this video, we'll explore the latest insights from the European Respiratory Society, ERS, and European Society of Intensive Care Medicine, ESICM, on how to assess and manage dyspnea in these patients, including strategies that combine pharmacological, non-pharmacological, and ventilatory interventions. Whether you're a healthcare professional or just interested in learning more about critical care, stay tuned as we dive into the science and clinical approaches that make a difference in patient care. Definition and challenges of dyspnea. Dyspnea is defined by the American Thoracic Society as a subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary in intensity. In the ICU, discomfort may not accurately convey the intense experience of patients, potentially lowering empathy and concern from healthcare professionals. A simpler definition, awareness of respiratory distress, is proposed to reflect multidimensionality and lived experience more effectively. Concept of respiratory-related brain suffering. Dyspnea can be conceptualized as a symptom of a broader brain process termed respiratory-related brain suffering. This process involves sensory and emotional brain responses to abnormal respiratory-related signals. Respiratory-related brain suffering can occur in patients who are minimally conscious or even unconscious, due to sedation, indicating that brain processes related to dyspnea can persist even without active self-reporting. The diagram represents the pathophysiological process of dyspnea and respiratory-related brain suffering, highlighting the interaction between respiratory stimuli, brain processing, and the resultant sensation and emotional response. Stimulus. Stimuli originate from respiratory system afferents or other sources, e.g., the heart, triggering increased afferent traffic to the brain. Brain processing. Perception and processing. The brain processes the afferent signals, balancing them with the efferent neural drive, corollary discharge. If there is an afferent-reafferent imbalance, the sensation can lead to distress. Emotion and sensation. The processed information can create either non-distressing sensations, e.g., exercise-related shortness of breath in healthy individuals, or distressing emotions when there is an imbalance. Respiratory suffering. When the afferent-reafferent imbalance leads to negative emotions, it results in respiratory suffering, which is distressing and accompanied by vegetative stress, e.g., heart rate changes. Behavioral manifestations, e.g., facial expressions, body movements, ultimately leading to the sensation of dyspnea. Neurophysiological and clinical biomarkers. Dyspnea and respiratory suffering can be observed through physical signs, neurophysiological biomarkers, EMG, EEG, and clinical biomarkers. The brain regions, like the sensory, motor, and limbic cortex, process signals from the lungs, airways, and chest wall. These signals are compared with the brain's efferent signals, the commands sent to the respiratory muscles, creating a corollary discharge. If these signals match, no problem. But if they don't, the brain senses distress, leading to respiratory-related brain suffering. Types of dyspnea include excessive effort, feeling like you're working too hard to breathe, air hunger, the sensation of not getting enough air, and chest tightness, often linked to bronchoconstriction. Ventilator settings also play a huge role. Underassist, when the ventilator doesn't give enough support, leading to more effort. Overassist, when the ventilator overcompensates, creating new imbalances. Short-term impact of dyspnea are immediate suffering, association with anxiety, impact on sleep, weaning from mechanical ventilation, risk for intubation. Middle-term impact of dyspnea, mortality and length of stay. Delayed impact of dyspnea, dark recollections and PTSD, suffocation and PTSD. How to find out this brain suffering due to respiratory distress. Patients who can self-report dyspnea can talk. Ask the patient directly about dyspnea using dyspnea scales. Cannot talk but can use other contact modes. Ask the patient using available communication methods, then use dyspnea scales to assess the intensity. Patients who cannot self-report and may have respiratory-related brain suffering, clinically unconscious. Look for signs using observation scales. Measure potential biomarkers, to be developed in the future, such as neurophysiological markers. Redundancy. The figure emphasizes that if there is doubt about the patient's condition, healthcare providers should ask, look, and measure in all contexts. This redundancy helps avoid missing signs of dyspnea or respiratory suffering in patients who may not be able to communicate consistently or at all. Monitoring. Continuous monitoring is encouraged for patients who are unable to communicate intentionally or when caregivers are not present at the bed. RDOS is the General Respiratory Distress Scale that assesses 8 clinical signs. ICRDOS and MVRDOS are adapted for specific clinical environments, adding objective scoring formulas for heart rate, respiratory rate, and oxygen support. These scales provide a structured way to infer dyspnea in non-communicative patients, particularly in ICU and mechanically ventilated scenarios. Here's how you can assess dyspnea and respiratory-related brain suffering, RRBS, in critically ill patients. Step 1. Initial assessment. First, check the patient's CAM ICU status and RASS scores, between -2 and +2, to see if they're able to participate in the assessment. Step 2. Communicative patients. If the patient is able to communicate, ask directly, do you feel short of breath? If no, dyspnea is unlikely. If yes, measure the intensity using DVAS, Dyspnea Visual Analog Scale, or DNRS, Numerical Rating Scale. If scores are DVAS greater than 3 or DNRS is greater than or equal to 4, clinically significant dyspnea is likely. Step 3. Non-communicative patients. For patients unable to communicate, assess based on their ventilation status, no mechanical ventilation. Use the RDOS is greater than or equal to 3 or ICRDOS is greater than or equal to 2.4 to detect RRBS. On mechanical ventilation, use RDOS is greater than or equal to 3 or MVRDOS is greater than or equal to 2.6. Step 4. Likelihood of clinically important RRBS. If the scores are below the thresholds, the patient is less likely to have clinically important RRBS. Step 5. Take action. If clinically important dyspnea or RRBS is detected, take relieving measures immediately. If not, continue to monitor the patient. That's it. This structured approach ensures no signs of respiratory distress go unnoticed, even for patients who can't communicate. Now we will discuss a comprehensive strategy for managing dyspnea and respiratory-related brain suffering, RRBS, in ICU patients. This is a multifaceted approach that covers both respiratory and non-respiratory factors, using pharmacological and non-pharmacological treatments. Step 1. Proactively identify dyspnea or RRBS. Always start by actively looking for signs of dyspnea or respiratory-related brain suffering in your patient. Step 2. Quantify the severity. Once identified, it's important to quantify the severity to guide your treatment approach. Step 3. Reduce non-respiratory stimuli. Correct non-respiratory factors like fever and acidosis that might increase ventilatory effort. Relieve anxiety and reassure the patient. Address any significant pain, which can add to the respiratory distress. Step 4. Correct abnormal respiratory impedance. Minimize airway resistance through suctioning or using bronchodilators. Maximize lung compliance by managing conditions like pneumothorax or pleuritis. Step 5. Adjust ventilator settings. Switch to pressure support ventilation if necessary. Increase inspiratory flow or pressure support to match the patient's respiratory effort. Offset intrinsic PEEP with external PEEP to balance pressure, and correct hypoxemia. Step 6. Use non-pharmacological interventions. Simple interventions like relaxing music or fresh air to the face can reduce emotional and affective dyspnea. Step 7. Consider pharmacological treatment. Low-dose opioids can help relieve dyspnea, and low-dose anxiolytics can manage the anxiety that often worsens it. This holistic approach ensures that every angle is covered, making a real difference in reducing suffering for ICU patients. Stay tuned for more insights.